Sound, Matthew?
Thanks for watching. Please like and subscribe to help us spread TIPA's positive approach message around the world.
It's good to see everybody. We've got quite a group in the Zoom room. And I know that we have people out there in YouTube world, or maybe not yet, but eventually you might join us. Now, we have Matthew who's going to monitor YouTube. We have Rachel who's going to be sharing out some questions that people have sent in and people in the Zoom room might be asking. And we also have Cindy, who's someone living with dementia who will be able to help us out with a perspective of someone with lived experience. We have Samantha, who's one of our certified team members, who's here to help support. Let's see, we have Jeffrey, who many of you might know, his work with his care support of his wife living in Colombia, South America. We have Cheryl Ann, who supports her and mom, your mom. And then we have Esther, who supports her mom and her dad supporting her mom. And we have a couple of other PAC certified folks. We have Jill and we have Denise, both of whom are folks that do a variety of things with PAC. They've taken a number of certifications. And we have some new people. We have Laura and we have Robin, who have not been before. So we want to welcome you into the Zoom room. So those of you out there in the bigger world, you'll see we have a variety of people here with different roles, different perspectives, and different life experiences. And I'm Tipa Snow, and I've been around a long time. So, yeah, Cheryl is also certified. Sorry, I didn't mean to say she wasn't. That's right. She's certified too. It's confusing. We have too many people with too many things. And Cindy's certified in living with dementia. So, we could give her that title. She's in the core team.
I have the paperwork to prove it.
And you have paperwork to prove it, although they might change your paperwork. We were talking about that earlier today on Let's Talk. Getting a good evaluation and a effective diagnosis treatment plan actually makes a difference. And for some people, and for other people, you're still looking for it. So, So here's a question. Are folks aware that there's a new medication that they would like to test? For a vaccine?
I'm sure there is.
Well, yes,
but I don't
it's a
want it.
vaccine. You don't want it. Oh, okay. Well, I thought I would share it out. This one is about a vaccine for Alzheimer's disease that's going to use amyloid beta immunogen with designer peptides to try to keep you from getting Alzheimer's. So that's one that's in the works. I thought I'd share that. So Cindy, you're saying you would not be interested in that. Tell me more about it. Oh, sure.
Whether I have it or not, I would not be interested in it because you don't know what you don't know. It's just like with the COVID shot. What did all the problems it caused? But it was safe and FDA approved, and now they're finding out it wasn't so good. I don't want to find out that something's going to put me in a worse place than where I am right now. And I'm not going to, right, I'm not going to get better. I'm going to die from it or something else. But so if you can't absolutely promise me that it's going to completely go away with a guarantee of some kind, I'm not going to do it.
So that's your experience, and your experience is no, thank you. I'm not interested.
Mhm.
So we have other people who are, and we believe that, okay, I mean, if you would like to try it, given the
Right.
sort of question of whether or not it's truly safe, knowing full well that in some cases it's not fully safe, there are risks, and you understand your risks and you're still interested, that may be something that some people are interested in. And we're in that zone right now where we don't have the fix. And so folks are sometimes interested in giving things a try. So other folks on here, What would you say, either for yourself or you were thinking about for somebody that you're interested in? What do you guys think? Would you want a vaccine that
Jeffrey.
might be helpful?
I think I would.
Jeffrey got his hand
Uh,
up.
Sorry, yeah. Hey, Jeffrey. So you can go, or
Hello.
who was? Let's see. I think it was. Go ahead, Jeffrey. You go first.
No, I was just going to say that I would take the vaccine, but I would not be willing to be in the trials for the vaccine.
Right.
Because I believe in the protocols for vaccines, the trials, have to have a certain efficacy that makes it worthwhile for the general population to take the vaccine. And I certainly, thinking about dementia, I am probably one of those people who would not want to live very long if I got dementia. So it'd be a lot better for me not to get it in the first place.
There you go. And so for you, not necessarily being in that trial group where we're trying to figure out does it or doesn't it. So when they're in the early testing of medications or drugs or things like that, vaccines, you're not really excited about being in that group. But if they've demonstrated that it could be and might very well be helpful in here's the limited risks or here's the risk, here's the benefit, then you would possibly choose to put yourself in a group there, maybe.
Yes. Because
Okay.
if I remember correctly, statistically, for a vaccine to be approved, it's got to go through 3 stages of testing. And the last stage, it has to prove that it works in more than 60% of the cases, I think, of people who are
Well, it
vaccinated.
depends on what you set your
Or,
target at. I mean,
yeah, I know
so
they're different
when we
ones. Some
say
of them
it
are much even
works,
higher.
yeah, yeah. I mean, when we say it works, it could be as simple. Now, this is where it gets a little tricky, that you will not show symptoms of dementia for 5 years after you get the vaccine.
But maybe you wouldn't have anyway.
Oh, shoot. Okay, well, there's that. I mean, but so what if it was going to be 10 years? Well, now we got to wait 10 years to see whether or not it has an impact at end of 10 years.
Mhm.
And so this is where often the trials are very short because
Mhm.
what we're trying to do is be able to demonstrate enough that people want the medication, we can move the drug development forward. The problem with vaccines, as I see it, one of the tricky parts is I want it to last, with Alzheimer's or any other form of dementia. If you're getting a vaccine and it's only going to be good for a year,
No
well,
point.
in that year, would you have developed dementia anyway, or would you not have? And so, was it actually doing anything during that year or not? And this is where it's going to get tricky on this particular phenomena. It's not like we're treating symptoms that you have. We're talking about trying to keep you from having a dementia, the symptoms of dementia, at least, which is what it's actually working on, um, and the development of beta amyloid, which is another indicator, but not necessarily, but for some dementias. So it gets a little tricky here. And I bring it up because it does come up occasionally as what do you think we should do? What should we do? Should we sign up for a trial or not? And I think people who understand what you're signing up for, even if you decide you want to do something, really making sure you understand the ins and outs of it for either yourself or somebody you care about, I think is important. So that you know what you're getting yourself into before you get too far down the road. Because it can sound like something, but it's like, wait a minute. So tell me what exactly the 60% is about. And that's where it
Right,
gets tricky,
because
Jeffrey.
too, with you not being able to get a good, reliable diagnosis,
Mhm.
how do I know that that's going to help me?
Oh,
Because, we get diagnosed 3, 4 different things. Depends on who you see when you see them. And so if it's not going to help everything and it's only going to help, I wouldn't know if it would work for me or not. So
I mean,
Yeah.
this is where it's sort of messy. I mean, it's still
Yeah.
messy because our ability to recognize that. So here's another new one that's coming out. So I wanted to share this one with you because this one, Arnie, and our friend who's living with dementia is the person who keeps bringing these up and finding them for me. Arnie's on the lookout. We count on him.
Yes.
So, a pill for Alzheimer's disease. Clinical trials on a new approach to treating Alzheimer's starts at 50 medical centers across the country. And this is an NIH funded trial will evaluate the effects of synthetic version of vitamin B1 on cognitive function. And what they're trying to find out is if you give someone a lot of B1, if you give them a lot of B1, a particular kind of B1, does it keep them from progressing and hold them steady? Because how somebody gets thiamine in their system depends on some B1, thiamine and B1. So you have a deficiency of thiamine when for many people living with Alzheimer's disease. So is this a way that you could get the thiamine in and the thiamine would keep them from getting dementia? It's a theory, it's a thought, it's a possibility. It is not something that we have evidence of. It is really, it's like this one doesn't have as many bad side effects. It's not as risky, so maybe it's worth exploring. But it's an exploration of a possible hypothesis. This is a hypothesis. We don't know the cause of Alzheimer's. We don't know the cause of the start of the symptoms sometimes. So I wanted to bring it up because I think sometimes people can get excited about this and think, okay, here we go. This is it. And it might be, but it might very well not be. And the thing about it is you have to catch it, again, as Cindy said, super early before you actually have many symptoms at all in order for this to be the thing they want to work on. So that's what they're looking for, is that. So I just wanted to share it out because we learned about it and I try to keep it up to date. So Jeffrey, your thoughts or your question, you have your hand up.
Yeah, I guess it was just that it's very interesting about vitamin B1 because I thought there is a dementia that is caused by vitamin B12 deficiency. Is there not?
There is,
Because
and there are some that are related to, now they're related. I wouldn't say they're caused by, but they're related to a B12 deficiency. We also know that alcohol will cause you to have problems with thiamine absorption. And so people who have alcohol related issues will often have a very problematic thiamine level. So it's related. B12, we know that nourishment, the gut and the brain have a relationship. We're still figuring out what does it mean to have a leaky brain barrier, and what does it mean to have problems in your gut, and which came first, and how is it impacting, and how are they interacting now? And we know we got lots of possibilities going on there. So I just thought I'd kick us off with some of this stuff that's going on out there because people are being exposed to it. And so I like to know sort of what people are being told and what they're hearing and what it means. So Cheryl Ann, what you got?
So I am doing that gut brain health study here in Tampa. And so I didn't know that I was going to get to hear my results from the year before. And so she showed me all my bacteria and she said, and you really don't have any of these 3 bacteria. And I thought, wow. And she said, those are the 3 good bacteria, the bacteria that helps recover and clean your brain. And I was like, what?
Oh, that's
Like,
that's
how is
not
that
good.
possible?
Wait. Yeah.
And then, of course, I took pictures of the paperwork and I brought home and I started studying them and like Googling because, you got to Google. And so one of the bacteria is not produced if you are vitamin D deficient. So I had just started like 2 or 3 weeks prior for my gastroenterologist taking vitamin D supplements. So I was like, oh, well, this is kind of, at first I was scared. I was like, oh my gosh, And then I thought, well, I have a leg up now, right? And it was something that I was already being treated for. So now, as I'm doing that, I'm like, okay, check, we're kind of working on this. My mom has vascular dementia, though. So that is from problems with her heart and stuff. So I also now have to watch my cholesterol. She's diabetic. There's just so many things to do. And so when I asked the head researcher, like, what is my best thing to do? And she said, eat a colorful plate. Don't eat the same foods every day. Like, God has created all these foods, enjoy them and stay away from like the food that you know is bad. McDonald's,
Yeah.
all the processed stuff. And I was like, well, it seems kind of basic, but surprise.
Surprise. Well,
Like,
basic
maybe
isn't a
basic is
bad
the
thing.
way to
We act
do.
like basic is a bad thing. And it's like,
Right.
well, actually, the things we can do, exercise, breathe. I always recommend
Sleep.
it. Breathing. Breathing is really important, it turns out. And what we breathe does matter. Getting out into spaces where we're breathing really good air and we're enjoying the breathing that we're doing. See things you love to see people you love to see, and exercise.
Mhm.
And take care of your diet. Yeah, but don't obsess about it. I mean, that's not the answer, I don't think. Evidence doesn't say obsessing about a diet is the right answer. Yeah, Big Macs. Yeah, geez, Matthew. Oh my heavens, we turn you loose out there and you're making comments about Big Macs. Denise, what were you going to comment on? You were saying something. What did you say? I saw something in the chat, but I was not paying attention.
So I don't know if this event, I've worked on two different clinical trials for dementia medications, which was a very interesting perspective. And couple of things I came away with is when they were screening people, there were very strict criteria that they had to look at. And if you were on certain medications, you couldn't participate. It wasn't just the cognitive stuff. So the first one that I worked on ended because of serious adverse effects, which meant people died.
Yep.
The second one stopped. I think it morphed into, I want to say, the first medication that came out a couple of years ago. Acatanab. Yeah, I think they kind of stopped it, but it went to a different direction. So, but my role ended, and I was working as an independent rater on this, but I was very aware of what the criteria were and what they were screening for. So, fascinating experience. I'm with you, Jeffrey. I'm not sure I would be signing up for a clinical trial, but that being said, we do need people that are willing. So but I also understand the reluctance to, and even when it comes to market, I will, this is me, my perspective. I have serious reservations about all these medications that have come on the market. And that's based on my having participated in two studies.
Yeah. I think really, we're not opposed to medications or drugs or anything else, but I think understanding what you're getting and appreciating what's happening for you. I mean, the number of people I see going from one or two medications to 15 over the course of a relatively short period of time is concerning, because we already know brains are changing, and then we add all these chemicals into the mix and into the change. And I think it's trying to treat an ever-changing brain chemistry with like a cocktail. And I'm not a big fan of throwing stuff at a wall and see if it sticks, because they're human beings that we're doing this, throwing this stuff at the wall. Both the family member who's trying to be supportive, but also the person who's living with the condition. I think we shortchange both if we just talk about, here's the medication that's going to make it happen. And it's like, let's be thoughtful about that, because rarely is a medication alone going to change what's going on and what's causing concern. We've got to address it as a multifactorial kind of phenomena, I think.
When they put it on TV
Mhm.
and they tell you in 5 or 6 words what it can do, and then the next 20, 30 seconds, they're telling you all the things that could happen, why would anybody want to take it?
It's
The
curious because
side
sometimes I
effects
listen
so
to it,
far
it's
out.
like, yeah. So I won't have a rash, but all of this could happen. I'm a little
And you could
concerned.
die.
Maybe I'll keep the rash. I don't know. It's just like, oh, let me think harder. Yeah. So, okay, Rachel. Oh, Jeffrey, one more question, and we're going to go back to Rachel.
I was just going to reply to Cindy a little bit there. And a lot of times, Cindy, caregivers are the ones who the medication is for, particularly with behaviors. When their person, their loved one living with brain change gets very aggressive or very difficult behaviors, it can be very difficult for them. And we know there's hallucinations and there's delusions. My wife had horrible delusional behavior. And I was the one who was freaking out and went to her doctor and said, she won't take any of her medications. She won't do this. I don't know what to do. And we put her on an antipsychotic. And that worked. And then what I was not told, I agree with you. They need to be better information about adverse reactions and potential problems and issues and things like that. Because I was never told that, well, as Teepa said, using antipsychotics is really like just throwing spaghetti at the wall and seeing if it sticks. The best antipsychotic, for example, I think is risperidone, but that is itself is only effective in like less than 40% of the cases. And the chance of developing akathisia, which is what my wife developed then, which is an uncontrollable body movement. You cannot stop moving your body. And the person who suffers it feels it. So my wife is suffering. She feels this akathisia and she can't do anything about it. And that's very distressing for me now. I have to live with that because that is now an irreversible condition that she got after prolonged use of an antipsychotic, because I was never told that the American Psychiatric Association guidelines for the use of antipsychotics is that one should try to wean the person off of the antipsychotics after 4 to 6 months. And my wife was on this thing for 2 years. And
Because once we put someone on something, people are more likely to add more things on. So we add another med to try to counteract rather than address the issue of like, okay, let's see if we can figure out have we eliminated, has the brain changed enough? Is the symptom not as pervasive? Are there some things we can do? And so, yeah, Jeffrey is now living with the result of not getting the information that could have been helpful information to make a more informed choice. And I think that's what we're talking about, is being truly informed and knowing what you're signing up for and knowing, how long you want to try something before you say, let's pause and let's see if we can come off of this. Let's drop the level down. Let's see if we can still make it work. Let's make sure that my skill level is what it should be. Let's see if we can change the environment. Let's see if her brain has changed. And we're in a different place. I mean, we just don't tend to be as, in my opinion, and this is pretty extensive background, in my opinion, we are not as careful as a health community when people are living with dementia. They are basically not treated at the same level of awareness as you can be if you are cognizant and you say, how long am I going to need to be on this? Let's talk about how I might come off of this. And I want to give it a trial of like a month. And if it's not resolving what I had us working on, we need to talk about dropping it back. The second group that I think gets short shrift is people with mental health issues, for sure. As well. But for sure, people living with dementia, it has been my experience, they are not viewed as equal partners in this process of trying to figure things out and holding ourselves accountable to best practice, which should be use the least for the shortest period of time and then start figuring out what else is an option. And we should not necessarily be turning to medications as chronic, because they rarely sustain their ability to function in the same way over time. Even things like Tylenol and aspirin, I mean, we find that there are impacts and there are effects that change over time if you just use it constantly. Jeffrey?
You just scared me a little bit there. No, I was just going to say that I read somewhere that people with dementia are the most under-medicated for pain in the medical profession. And I actually do have my wife on a low-dose Tylenol regime, 500 milligrams 3 times a day, because I don't think she can express pain. And as a matter of fact, I realized that today.
She can't express that she's having pain, but she's having pain, but she can't tell you that she's having you pain.
Right. She cannot verbalize.
That.
I'm sorry. She cannot verbalize the pain. The pain might manifest itself through her behaviors, obviously. And for me, of course, then I have the difficulty. Is it pain? Is it her akathisia? Is it something else? What I'm constantly guessing. But it's just, I mean, my wife is probably Pearl right now, and she had her first fall today, a few hours ago, in 2 years, unfortunately. And that was my fault because I had her hang onto a chair that slipped out from under her.
Okay, we're going to pause there. Okay, pause right now. I'm hitting the timeout button. Pause. She reached for the chair. It was not as stable as you thought it was. It's called a mistake. It is not called Jeffrey's fault.
It was Jeffrey's. I'm sorry, Dave, but it was Jeffrey's fault because Jeffrey should have known that when he had her standing and holding on to the back of the chair, that if she pulled on the chair, it wasn't going to stay stable.
He stood and held on to the back of a chair before.
Oh, she's done it before, yeah. But I've been with her at work, but it's been when helping her get dressed and undressed. So I am touching her body in a different way. This time,
I'm not letting you own this, Jeffrey. I mean, you can keep trying to pick it up and carry the stick and beat yourself on the back. And I am going to pull the stick out of your hand and say, quit doing that. That is not helpful. How many times this is Teepa getting on. So
anyway, I was just going to, my point was, I'll stop that, but I still feel like I'm at fault. But my point was, she hit her head on the back of her head on a door, on a cabinet door next to the toilet. Yep. She fell down on the floor and hit her head. And she got a big bump on her head. Fortunately, no bleeding, no open wound. She never lost consciousness. But she also never said, ow. She never said, ouch. She never expressed a word of pain.
Yep.
And I took her temperature. We took her vital signs. She started getting a little fever right away. So I said, maybe we'll do something. So we gave her Tylenol to help bring the fever down. And throughout this entire process, there was not a peep out of her as to how she was feeling or what her experience was. And I had to constantly be guessing and using the best of my abilities. You know, fortunately, I had a nurse with me. She was having her lunch break at the time, but was monitoring her and everything. We made sure she didn't fall asleep. You know, all the things you do when someone's had a head injury or a fall. You don't let them fall asleep at all. But my point was just that there's zero manifestation of pain, and I'm sure that hurt.
I'm sure it is too. And so one of the tricky parts is the part of the brain that allows you to express pain is different than the part of your brain that registers that you're in pain. And so it's not people who are living with dementia. Cindy can tell her experience. I have people who say, I feel pain where I shouldn't feel pain. Simply gripping a chair tight can make my hand ache. And it's illogical. I know that it's stupid, but I can't make my hand not hurt. And yet I can actually burn my hand. I can see I have a huge blister and I don't feel it. And I don't understand how I can't feel it. But then my foot is killing me. And it's like, okay, so it's referred pain. Somehow your brain is taking signals and putting them in different places. And so this brain of ours is such an interesting phenomena. And the reality is, the rule of thumb in practice is if you would have had pain when this happened to you, Jeffrey, then we should offer a pain medication to someone living with dementia. Because if you fell backwards and cracked your head like that, would you think you would have pain?
I'm sure I would, which is I guess when I said I followed your advice. I guess I gave her pain relief immediately.
Absolutely, because it's also going to serve to reduce the swelling. It's going to serve to get rid of some of the tissue that's going to get into that area. So it's good practice for a variety of reasons. But the most important is you're responding in a way that makes sense. And that's the best we can do sometimes, is use our brains to support the brain that's changing. But what I would also say to you is, how many times have we talked about she's going to fall? Jeffrey, how many times have we said that? How many times over the course of the times we've taught? How many times has it, she's going to fall? She is going to fall. How many times have we said it?
Oh, how many times I said? Well,
Have I said that? Have I said to you that to you? She is going to fall. She is going to fall. How many times have I said that?
Have you told that to me?
Uh-huh.
Oh, I'm sure you've said it at least
many
a dozen
Oh,
times or more, that it's inevitable that people fall. But that is why I have had in-home care, and I tell them you
When
cannot
you have
leave.
in-home care, she will not fall. Is that what I told you, Jeffrey? Is that what I have said?
No, you did not say that.
If I said you watch her like a hawk, you watch her like a frigging hawk, you have your
Yes, we
hands on
do.
her, will she fall? Will she still fall? Did I tell you she would still fall? You see these nodding heads, Jeffrey? The rest of them have been in the groups when I have said this to
Well,
you, right?
yeah.
Nod your head, yes, Jeffrey. This is not Jeffrey's fault. This is the inevitable fall that I told you about. And you could have had your hands right on her and she still could have done it. This is so tricky. Our desire to keep people safe is so intense. And yet, do this, Jeffrey, with me. Do this right now. Get those hands up there. You got to let go of the sense that I own this. You don't. You don't own it. You do the best you can do. And then you say, wow, I wish that hadn't happened. That sucks. And then we move forward with what we got.
Tifa, I'm curious with the parents. Hey, everybody. Sorry I'm late. And if you're breathing in the background, it's a dog, I swear. German Shepherds are the loudest breathers on the planet. It's just a couple people like, yep, I had no idea. I'm curious about the parents out there. How many of you guys are parents or grandparents or even any sort of parenting exposure if you are like the most involved aunt, uncle? How many of you guys have watched toddlers, and I mean true, like the ones that are like off balance, walking around in the world? Okay. And I'm curious, with their developing neurobrains, how many of you guys have seen them fall and literally you almost watched it go? You may have, even when they got older, told them it's going to happen. Now, how many of you guys are sitting here thinking about that time when your toddler fell and thinking, oh, if I had only been there, if I'd only done it. So why is it, I'm curious, that we're okay with our toddlers falling in a developing brain? But why is it that we, and Jeffrey, I don't think you're alone in this, feel guilty and take on the fall when it comes to dementia? Like it's something, as I'm watching this, realizing, oh man, I'm not even seeing it as new learning moment as their brains are changing, but ours are too, to go, now I know. The chair is no longer the thing that's stable enough for her. So I'm curious, how is it that we are seeing this differently? When it's a developing brain, why do you think we're able to let it go and recognize new walkers, new the kids are?
Esther, what have you got? I've got a few. Let's see what Esther has.
Kids are made out of rubber, so when they fall, they still
bounce.
seem to, yeah, they're very resilient. They sort of just kind of get up and, brush it off and keep going. But I think when an older person falls, I at least get such anxiety that they're going to break a bone or they're going to, and
So
then it'll
let's
start
pause,
that whole
Esther, because you're
domino
right.
effect.
Okay, Esther, pause. That's good. Jeffrey, did she break a bone? Did your wife break a bone?
You're talking to me.
Yeah,
No.
did your wife break a bone? Did she get back up?
No, I had to
Did you
pull her
help
up.
her back up?
I helped her back up.
Did
Yes.
she get back up? Did she start walking when she got back up?
Yes.
Oh, huh.
She was
There
still
you
able
go.
to walk. She was still able to walk. However, she's still well. I don't know.
We know
I
where
think
the direction of travel is.
if I can, well, if I can, I don't know what I say, defend myself, but anyways, if I can make a comment as to why I am so preoccupied by it, I guess it's because I read in online support groups too many cases where the loved ones, people living with brain change, have a fall. They're sent to the hospital where they then have surgery
You're going to
that
do
makes
that?
them immobile.
Are,
No, and I have, but this is the whole point: is this is why it scares me, of course, Tipa, is because I have told myself, if my wife breaks her hip, falls and breaks her hip, I am not hospitalizing her.
Mhm.
And I realize that's the end of her life, because
Either
the only thing
way.
we can do is put her on pain relief and see what happens.
Yep.
Because I mean, it's all about prevention. And that's why it's just, when I fail to
gang shit.
prevent something that I know it could lead to her death, it's, I
It
mean,
feels
okay.
bigger.
It
But
feels
how
difficult.
many
I mean, I know we
times-
agree. Listen, she has a terminal illness. She is dying. She's
But
going
how
to
many
die.
times did
I
the
agree.
chair work?
There you go. Cindy's, how many times did the chair work for you?
It was working
had
for me
no-
for months.
Right. So you have no reason to think it's not going to work this time.
The learning moment.
Can I ask if your
Yeah,
wife
okay,
has
yeah.
fallen before and like broken anything?
No.
No.
My
Her
mom has
her
fallen
last fall was 2
probably
years ago.
over 50 times. We don't know how she hasn't hit her head and had a bleed.
Mhm.
She's remarkably good at falling, even. So, I mean, but she has had fractures and stuff. She has been to the hospital. It's not the end of the world. She has
Uh-huh.
returned home and then later on in the nursing home to care. So I think falls are just something you have to learn to live with because they're going to happen. And it's not always going to be the worst case scenario. At least that's been our experience.
Yeah, and so Jeffrey has tried so hard. He has worked so freaking hard to not have a fall. This is so disappointing that however hard you worked, you couldn't keep her from falling. And what we're all saying is, yeah, Jeffrey, do this with your hand. One last thing before we leave you alone. We will leave you alone at this point. Do this. Risk taker, safety seeker. Put your hand way low and go safety seeker.
I have no idea what
Risk
you're asking me
taker.
to do.
Put your hand way high and say, I'm a risk taker. Put your hand
Risk
way low
taker.
and say, I am a safety seeker.
Safety seeker.
Is your wife a safety seeker or a risk taker when it comes to moving?
Well, I'd say she's a risk taker of sorts. I mean,
She is.
But I spent the whole time trying to write down how different she is now versus a year ago.
She's still a risk taker. She's moving.
Yeah, she's moving.
believes in
Exactly. She
moving.
cannot.
She will not quit moving.
She cannot get off the toilet by herself once she's on the toilet, but she can get out of her chair.
And she does.
And she does.
Yeah. And she does. She's a risk taker.
And she will fall again.
And she's going to fall again because she's going to sneak out. Here's the thing. I mean, it's really hard for us, but I can say for myself, I would much rather take that risk than be tied down. I know that. I know that about me. And I also know if people try to make me sit down, you're more likely to get me so stirred up that when I move, I'll move with less skill because I'll be pissed off. I mean, that's just a reality of me. I mean, I've never done well with restraint.
I have to admit, I haven't thought of that, and I appreciate your comment because I do because of my wife's akathisia, we used to sit down in separate chairs after lunch so I could have my coffee while her nurse has her lunch. Now I sit next to her on the sofa, but I've got her footrest for her, but she won't sit still. She cannot sit still. It's not that she won't. She cannot sit still.
She cannot sit still.
Her body
requires
it
movement.
literally moves every second. Sometimes
Yep.
her legs
Yeah.
goes up, goes down, legs goes up, goes down. And I do sometimes even trying to
hold it
sit
down.
next to her,
Yeah.
holding her and asking her to lean on my shoulder, just relax a bit and take some deep breaths, still doesn't work. And she gets up. So I've learned, I did it today. This was the thing. This was a result of all. She got up and I said, okay, I can't keep her down. So I'm going to go walk with her, even though I don't want to. I'm going to walk with her because that's the only way I can feel safe. I'm not going to let her walk alone. So I walked with her and we went to 2 different bathrooms. Each time we went into the bathroom, I asked her, do you need to use the toilet? She said, no. We get back to the lounge, the living room, and I sit her down and I smell something.
So Jeffrey, how many times?
So I walked her back to the big bathroom where I have all this space, the shower, the open shower, everything, and that's where the accident happened. Because I was trying to clean her, and I should have just.
So frustrating. If you could just be inside her head at the right moments to interpret what it was she was trying to say to you, this would be so much easier. You know what we need? We need an experiment where we put an electrode system over her head to your head, and then we hook you together, and then you could read her mind.
Yeah, the problem is, as we've learned with brain change, I don't know how much of her mind is left. Because when I look at, she looks there at lunch, and I
guess
ask
what
her,
she would have said when she was in the bathroom? Hey, Jeffrey, yes, I need to poop. She didn't not do it, but when we took her and she looked at the toilet, probably her brain went, oh, good idea, I'll take care of that. Unfortunately, she was not on the pot when that happened.
That's true.
But it was a nice visual cue. That's what I should be doing. Sure enough, let me get that taken care of. Oh, I'm glad she's safe, Jeffrey. And I'm glad you gave her Tylenol.
Well,
and I'm also glad you're talking about it. And I'm glad we're letting some of that anxiety that you've been with all the rest of the day out. And I'm glad you have other people in the room who are riding you just as hard as I am.
Well, you know what? The funny thing is the nurse asked her, did an interrogation. We're not supposed to interrogate, we know, but she asked her, what's your name? And she said Jacqueline, but then she used her maiden name as a surname instead of my married name. Said, well, at least she got something. That's because that's the 35-year-old memory is not a recent enough, not an old enough memory to be remembered. It's got to be way, way back.
Yeah.
I started doing that too.
Yeah.
I would say use my maiden name when I talk. Somebody says
your address from your childhood. I mean, it just pops out of your mouth in those moments. So, Jeffrey, if this were to start a hematoma and she were to go to sleep and not wake up in 3 days, would that be the worst possible thing for her end of her journey?
You're saying if she would not wake up for 3 days or at all?
Say if she hurt her head and this time there was a hematoma. I don't think that's what you have. But if there was a hematoma and in 3 days she got more and more somnolent, she just quietly went into sleep state and she didn't wake back up, would that be the worst possible consequences?
No, I would say no, it's not. No.
Would you be okay?
Because I don't think she would be suffering. I mean, my wife has, I do very well take control of her blood pressure because in one of her CAT scans, they found an aneurysm in the artery at the base of her brain. And I guess, well, we got to keep her blood pressure down to prevent that from bursting. And I always say to myself, that's the way I'd prefer her to go, to be honest. Quick and without pain.
And so that idea of recognizing, she didn't break anything. And we don't know. I mean, we never know what the end of our story is going to be. It's just you are doing an amazing job. And my writing you is to really help you let go of that idea that you should be doing something more or something different. I think you're doing a remarkable job, and giving yourself permission to make mistakes is part of doing this remarkable job, and realize mistake has to happen for you to realize, oh, now I have new. And thank heaven she didn't break anything. So now you learned about the chair without her breaking anything. Congratulations. I don't know what else to say, because frankly, up till now, you'd been able to use the chair.
No, yeah.
Now you know. And it hurts, but it's just the way life happens for human beings. I mean, we make a mistake, and sometimes it's a major one, and sometimes it's just the minor. It doesn't matter. Yeah. All right, Rachel. What other questions might have come in during this period of time? Thanks for working with us. And we got to cover some topics of interest, I think, for folks, and talk about concerns. The reason falls happen is that 1 out of 4 people, the reason for their demise ultimately is a fall. It's related to a fall. The most common is pneumonia. People get pneumonia. They can't fight infections. And the reason they can't do that is the system is just to a point where it can't mount resistance to an infection, and the system starts shutting down. We also have high on the list dehydration and system failure, because dehydration and malnutrition go hand in hand. And it's not because you're not trying to put food in, it's just that it's not being used effectively by the system. And then the last one, there's all kinds of possibilities. We got septicemia, which is where you get an infection in the bloodstream. We have problems with blood pressure, blood sugar. We have heart attack. We have stroke. There are lots of other alternatives, but and there's just giving up living. People can give up living because I've done enough. Thanks. I don't need to do anymore. I think I'm done. So we have all kinds of reasons we exit. Sometimes it's just time. Rachel, what you got?
So Tiva, we had kind of an intense situation, but before that, we had 2 kind of more practical, hands-on kind of questions. One had to do with, how do you help someone tolerating having an IV inserted? And the other one has to do with contractures and what's possible and how to help with that.
So let's do IV insertion. And this is where we will do double hand under hand. And so one hand under hand is on the arm that's going to get the IV. Let's say they're going to put the IV here, they're going to put it here, they're going to put it somewhere on this arm. I would want the person who's supporting me to be in hand under hand there. The second arm will come under the elbow against the chest wall and hold onto my left hand and stabilize me. Then they're going to say, this is going to pinch. Okay, breathe with me. She's going to okay, there we go. It's in. It's in. Okay, now breathe. Good. Now they're going to tape it down. And so I'm telling people what's happening while I'm stabilizing the extremity, while I'm holding the wrist flat, while I'm creating a lot of relationship. And I have the responsibility of saying, pause, we're not ready yet. My job is to support the person who's having the IV inserted. The IV inserter is responsible to listening to me as the partner. And my job is to stabilize and say, this isn't easy. You're doing a great job. Good, we're there. We're there. All right, now they're going to take the tourniquet off. Yeah, that feels better. All right, now here's the tricky part. You got to leave this in, and that's going to be uncomfortable. So what we're going to do is we're going to put a sock up over that. We've cut the toe of the sock out. We've got a hole for your thumb, and we're going to put it over top. And that's going to help your brain not see that every time you look at your hand. We're also going to see about what else we need to do to help you tolerate this if it has to be in. So one of the questions is, should they have put it in the non-dominant hand? Well, The problem with putting it in the non-dominant hand is that I have a very skillful dominant hand to take it out. Whereas if you put it in my dominant hand and you have me doing some other things, I might actually have something to drink, give me something to eat, give me something to do with my hands, and make sure that you've got that well established and it is as comfortable as you can get it, and that my joint is stabilized. And we want it in a place where we can actually, if at all possible, be able to bend and move the arm without it really interfering with that movement. Because if you try to limit my movement, just as we've said with Jeffrey, you try to restrain it, then I am more likely to want to get it out because it's restricting what I want to be able to do. And one of the worst things we used to do to people living with dementia is tie their arm to the bed rail or to the frame of the bed to keep their hand away. And we tie both of them down. That was the old habit. Or put a mitt on them and then tie them down. And the problem with doing that is it creates a sense of being frantic in the person because I can't use either of my hands. I'm wiggling around and trying to get in the bed. And so what ends up happening is I create more distress for myself. And ultimately, if at all possible, I'll figure out how to, and I've seen it so many times, I'll figure out how to get my mouth down to the thing to get it out. Just like for G tubes, people will try to work them out because they're so, what it tells me is that's discomfort moving to pain. And when I have something that's so uncomfortable that it's painful, I need to address that. I don't need to restrain somebody. I've got to figure out, okay, what's so uncomfortable about that they're having a really hard time with it? And who can I call in to help somebody tolerate this thing? And our challenge is we tend to want people living with dementia to tolerate the intolerable without helping. And when folks can't do that, we want to use restraints. And it's like, we need to learn how to use resources to support somebody tolerating something that doesn't make sense to my brain. People pulling out catheters, people pull out catheters because they don't think they belong where they are, and it's uncomfortable and it's actually bothering me. So we've got to figure out how we would do that in a way that helps somebody tolerate what is intolerable. And I would say there are times when we have to decide, okay, is it worth them trying to pull it out for the third time? Or do we need to pause here and rethink what we're trying to do with this intervention that we're doing? Because I think sometimes we get so invested in the intervention, we're not looking at, okay, but why are we doing the intervention? Is it for convenience or is there a really specific purpose for it? Is it because it's easier to deliver the meds 3 IV? Or is it truly that they're super dehydrated and it's an episode of dehydration that if we fix this episode, they can come back online and they're going to be present and they're going to be happy to be alive for a while? So Cindy, what do you think about that? If you had gotten an IV because you were dehydrated, acutely dehydrated, and you came back to where you are right now, would you be okay with that?
What? As long as they don't try and tie me down.
Oh.
They tie me down, we're screwed because I will fight to get loose. It doesn't matter what, I will.
Yeah. And so
even while I'm, not dehydrated, I would do that. So, because when you're dehydrated, you're not really thinking clearly.
Yeah.
So I'm still going to fight.
Yeah. So if we know that about you, then we need to create a game plan that keeps you in mind, because this game plan needs to be about you, not about my treatment modality. And I just need you to behave yourself so I can do my treatment modality. And I think what we keep forgetting is the person is a person first, and we got to work with that human being instead of thinking it's okay to do things to that human being and sedate them or control them in such a way as to be able to do this thing that we want to do. And so, Cindy, if I have to start restraining you all the time for a while, Are you saying that you'd rather not be rehydrated and you would rather be let to move forward in your process of whatever that means versus tying you down and trying to hydrate you? And you understand that that means you might not be able to live. And you're still making that choice.
Yeah, tying me down is, yes. Me down
Okay.
is not going to be good for you or for me.
Okay. And so this hard part for us, the hard part for us is hearing what Cindy said, knowing Cindy is quite competent to make that choice about herself, even with her dementia. I know Cindy is speaking truth to me. I mean, that is Cindy. That's just who she is. And it's not going to change at this moment. She's not different than she was when she said that before. She's still that same woman. Um, and I got to hear that. And I've got to, if I'm her advocate, I've got to basically advocate for what Cindy's saying, not what my brain wants, which is I want Cindy to be safe. I want her to get rehydrated because I know she can come back to right where she is right now. And Cindy is like, I don't really give a friggin' whatever. I don't want to come
Right.
back if I have to go through that. That's not okay with me.
Right.
And that's what people have a hard time hearing.
And being able to honor it. Because I can say it, but that doesn't mean you as my partner is gonna go along with me.
Yeah.
Because I'm not in my right mind, and there are people, I mean, you can have it all written out, but if they choose to not follow that, that's their choice.
So you
And I
really
have
want to
no
pick
say.
your advocate really, really carefully and really make sure they get who you are and that they
Right.
honor that they're committed to honoring that. Yeah. Yeah. Ooh. Yeah. So yeah, we've talked about what if somebody changes their mind. Because I've had people say, well, I'm okay with having, I mean, they never want to puree food. Let's a simple example. I never want to eat puree food. If I have to be fed and I have to eat puree food, I'll want to die. I know that. And then I get there and it's like, it's okay. Feed me. I'm good with puree. And how do you know that? Because I accept the puree and I'm here and you're feeding me. And I seem to be enjoying myself. So what do we do then? And it's like, well, now I'm not exactly how I was before, and I'm showing you evidence that I'm okay with it. If Cindy's, I take her wrist and I put her wrist down and I hold her wrist down and she just lays there and she doesn't fight me, well, then maybe she has changed her mind. Now I have to sort of work with, oh shit. Now and I would say an oh shit moment. It's an oh shit moment because I don't know if it's a temporary thing or as she starts to come back, she starts fighting again. Then it's like, okay, all bets off. Here's where we talked about it. Maybe she was just so dehydrated that she was not able to move at all. Now that she's back to where she's more herself, she's fighting again. And it's like, okay, time, we're calling it. IVs come out. That's what she said. And that
But
ability to
some of
make it,
that baby food is pretty darn tasty.
you're into it. And
It's,
I still remember the meat.
oh, I mean, like they have tutti frutti.
Yeah, this
That
is
is
the
so
thing, the meat
good.
sticks in my mind. I don't remember which of my children. I decided I would taste it before I made them eat it. And I tasted it
Yeah,
and I never made them eat
yeah,
it. Yeah,
me
I
either.
can't do it. Can't do it. I would never put that in a child's
Nope.
mouth. No wonder it comes back out. So we ground things up that I ate. That was okay. Yeah. If they can't handle ground, they shouldn't be having it anyway. Sorry. All right. Gosh, I love it. All right. So Rachel, we had a question coming up in the Zoom room, or you had another one. We had a complicated one. I know that.
Well, we had one about contractures, which I
Contractures.
thought might be worth kind of talking about, especially when someone's arm is pulling in and hands pulling in. We've had someone say, well, we can do the lamb's wool splint, but there's not really anything we can do. And they weren't even really sure, how do you get in clean? What can you do? And people were being told there's nothing we can do, and they're finding that hard to swallow.
Yeah. So let's talk about what happens when you have a contracture. So the upper part of your brain up here, put your hands right up here if you would. up in this chunk of brain is where you have sensory information coming into your brain and motor impulses leaving your brain. And they go to the opposite sides of your body. Now, this part of your brain, its task is actually to tell your muscles to relax. I don't need you. That's its primary function. So the cortical part of your brain is to cause muscle relaxation. Other parts cause your muscles to tense. Now, the muscles that are stronger tend to be the ones we see, the pattern that we see. And so the muscles that are strongest in the upper body, the upper extremity, are the ones that pull your arms in towards your sides. They bring them in. It's called adduction. They add in. The next sets of muscles are the shoulder muscles that cause, and the ones that are strongest are these big pecs, these pectoralis major muscles. And so they pull your arms inward. So not only do they pull them in, they pull them inward and rotate them inward. And then we have the muscles that cause your biceps to flex. And your biceps is stronger classically than your triceps. So your biceps pull in, and that causes your elbow to flex. And then the muscles in the palm of in the forearm that control your fingers, these are all ligaments up here. And the muscles are down here in your forearm. You can see the ligaments running through your wrist. There are some in your hand, but the ones we're talking about right now are the ones that cause your hand to curl down and in. And these are a lot stronger than the ones that cause your hand to open, which are on the back of your wrist. They all run on the back of your wrist. And they run across all these joints. And so what ends up happening is all the joints flex. And your thumb is going to pull in close to the palm because this muscle, this is an adduct, this muscle pulls it in. And so I've got these, and the wrist drops down. And so now I have my arms like this and my hands like that. And I don't have a lot of options to stretch them out because I don't have the ability to relax all the sets of muscles here so that I can do this active movement. So what we know is that the best kind of movement to help me relax a little bit is called a rotary movement, and we move people into the pattern that they're in. We don't try to pull them out away because what you'll get is all that resistance. And you also get what's called rebound, which is if you get it out, then it pulls in even tighter. And that was one of the challenges when we put on the splints or we put the carrot in there. When we put this carrot, that's something that's shaped like a carrot, so it has a narrower end at the bottom and a wider one at the top, or we use the splints, we could push the fingers out, but then what would start happening is they curl up on top of the splint, or we would actually start to see the ligaments tear loose from the bones, or they would sublux. And so we would get hands that would be like that. So the tricky part here is we can do things to help relax a little. It's not going to be much, but if I get the elbow forward and up, we can now clean the armpit from, and you'd want to do it from the back of the body forward, but you can get all the way in the armpit and then you prop the elbow up on a pillow in the bed. The person's more inside lying or into the front. And that allows that area to get air. And that's how you get rid of bacteria and you keep skin from actually getting really mushy and nasty and starting to slough off because it's not getting enough oxygen to it. And the bacteria and the microbes are not building up in here, and you don't have yeast infections nearly as frequently. So the next one is to start thinking about rotating the forearm back and forth around a little so that I can get it out. And if I work with somebody, I can get it out maybe to 90 degrees. Well, what that's going to allow me to do is then clean the crease in the elbow. And then I do that. And again, I prop. And then comes the trying to help the hand relax a little bit. And again, it's a rotary movement, it's slow, it's rhythmic, and you want to take the tips of your fingers and bring them here so that I can lift the fingers out and it's just coming up underneath and supporting from the back just enough that we can get in there to clean the hand. And then we dry the hand and we have the hand rest on another body part for a little bit. Now, it doesn't mean it won't close back up, but what it does mean is we got oxygen and we cleaned it, and we've actually got a person more comfortable for a short window of time, because I can't turn these muscles off. And so it makes your muscles sore and tired to be on all the time. And so it does feel good to have somebody work with you if they know what they're doing. But that doesn't mean I want to put you in a splint that holds you in that when your muscles start to pull back, you don't have a way to come out of it. And so from my days in head injury, we would go in the room, and we used to do this all the time. We put them in splints, and we'd go in the room and the splint was off. It's like, how the hell did they get the splint off? I don't know. We watch them on film, and they would be using their teeth. They'd be gnawing at it. They'd get their other hand. They'd try to gradually work because it hurt. And so what we know is that we have to start to listen to what people are showing us. And so I have not used any splints on people who are at the late state of a dementia, because I'm not going to win this battle. And so figuring out how to help somebody get clean episodically, and then doing some massage in the hand. I have been successful at getting in most people's hands and getting them relaxed, and really remarkably for some people, they're like, wow. I will tell you that it's been a while for some people when you smell what it smells like, because that's a lot of bacteria building up in there and a lot of dead tissue. And what we want to do is get into the habit of doing this more routinely so that we're getting that care done more routinely. And it means that's where we should be spending time with people. And it's not just sort of warehousing. It's really seeing this as an individualized care approach where we're actually going to do this work because it feels better to somebody. And people breathe better and they relax, and you can watch their body relax when you're doing this work, if you're doing it the way that their body likes it and they like it. So it's a process. So yeah. Yeah, so Beth has a Pearl video in bed. I know we've done that late state care video, and we go over a lot of these techniques in that late state care video.
That's a great one.
And it's not taught, and that's the sad part, is we don't really see this as something that we should teach people to do, and that's the challenge.
I think having that awareness and knowing, even with just this visual, and knowing, walking away from here, oh, there's something I could do differently. I will do a quick share screen just for the visual, because it's kind of remarkable to see.
That's it.
And you can see her legs, how completely comfortably crossed over they are.
Okay.
But we've learned it's not exactly comfortable.
Now, first of all, I'm going to put on your socks.
So I will fast forward real quickly.
Get out.
And how you end up supporting. There's a way to support the leg to bring it up. I won't go into this. That isn't what we're talking about here. This idea that knowing that if you are working with somebody that has those level of contractures, there's a way to work with that contracture. That reflex is what Teepa's talking about. So that visual may help you. Pearl's upper body, her arms weren't ever that contracture, but her legs, if you just try in that moment, wherever you are, to get in that position where your legs are just parallel to each other, your lower legs, and how much twisting it takes, it really says a lot about how engaged those bigger muscles are to have twisted her body that way. And Teepa has ways in which we've learned, and many actually occupational therapists and speech therapists or physical therapists can also help you, but they actually may not know about working with the reflex versus slowly getting movement and slowly pulling apart. So just as a cautionary statement, let us know if you're looking for more resources on this.
Yeah. And the thing about the lower extremity is where you see this joint over joint over joint for the muscles. In the lower extremity, it comes from your low back. And so those muscles go from the low back to the front, past your knees to your shins. And that's why those legs pull up and in that way, because that's how those muscles run past several joints. So, yeah. So there we go. Rachel, now I'm going to turn it back to you because I think we did justice to that one as much as I can without a real person being able to demonstrate it here.
Yeah,
And it's a
but that
little late in the
helps.
building. Yeah.
So, we did have a question from our room here about someone wanting to go home and can I come with you? So, Robin, you want to take it away?
Yes, that's me. First of all, I just want to thank Tifa and especially Cindy and everyone here. Cindy, thank you for sharing your perspective. And Tifa, you've been so helpful to me. I've navigated so much of this with your help. So I just want to say everything you put out there is just incredible. I did watch your video on I Want to Go Home several times, actually. And just to give you a little background about my mom,
Yeah.
she's had dementia, I would say about 8 years now.
Okay.
She unfortunately had a lot of psych illness before, and it initially presented as a lot of anxiety, which I feel absolutely horrible for her. So we weren't quite savvy yet as to what was going on. She lived at home for a while, then she was with my sister, and she's at the point with a lot of other physical illnesses where we couldn't take care of her anymore. And she's actually at a really wonderful nursing home called Friendly Home, which is one of the best ones. Yeah, I don't know if you've heard of it, but their approach is very patient-centered. She hates it there. She thinks it's
She
a
does.
dump.
Yeah.
Yeah. I unfortunately have medical issues. I'm in bed. I'm bedridden. I can't be there with her, but I do call her as much as I can. And most recently, we were doing I Want to Go Home, and we were kind of working through that. And now we're at, can I come and stay with you for a few days? And she has it all mapped out where she'll stay. She's going to get food delivered, even though she can't use her phone anymore, all of that. And I'm trying to support her without a lot of tears.
Right.
But this is the first time I've really been struggling to kind of get through the conversation without, arguing or whatever. So I would love any suggestions that you have.
Yeah. So she's very clear about, I want to be with you. And
Yes.
I want to be with you exclusively. And I'm willing to do whatever I need to do so that I can help take care of you and we can be together. So
Mhm.
she is actually skillful at trying to create the opportunity to be with you. So she wants to be your mom again.
Mhm.
Okay.
Or anybody in the family.
Or anybody. Yeah. I mean,
we're
but
calling
what
her
she's
jailbreak Jan.
yeah. So she's really saying this place that I'm in is
Not
not
for
my
her.
family, and I love family, and I'd rather be with
Yes.
family. And that's
100%.
that's her message for sure. And
Yeah.
how I'm curious about the possibility of this is really hard, mom. And I absolutely hate it for you. And I hear you saying you hate this place and you hate being there. And it just seems ridiculous that you can't come and be with us. And I hear that. And it hurts that I can't figure out a way to make that happen
Yes.
for us. It just really hurts because, oh, hey, mom, I have a question for you. Now, what did you hear me do before I got to this point?
You were very sympathetic to the feelings that she was experiencing.
Affirm, affirm, affirm. I got your message. I get it. I hear exactly what you're asking for. And what you're asking for is absolutely, I makes sense. And I wish I could. I hate it. Oh, hey, mom. Now, what I did is I completed that cycle. I gave her everything I could give her because I can't give her the house. I can't bring her here. I can't get her even out. You don't even have the capacity to go and get her and take her out.
No.
I mean, that's the reality. I mean, I wish it were different for you because it hurts you that you don't have the capacity to go do that right now. It's killing
Oh,
you.
yes, very much. Yeah.
Yeah. And so acknowledging I can't do that right now to yourself. I mean, it's just a reality. You can't do it. So what I can do is interject myself. So it's like, oh, hey, mom, I have a question for you. When we used to have to be in school, do you remember us having to be in school and we didn't want to be in school? Do you ever remember us not wanting to be in school? Because I sure remember not wanting to be there. Do you remember what you used to tell us when we had to be in school and we didn't want to be there? What did you
You
tell
got to
us?
do it.
We got to do it. It sucks. Yeah. And we're sort of at that same place. So here's what I wonder though, mom. You know, I love you. You know, I love you.
Yes.
You know, if I could, I would come and get you. You know that, right?
Yes.
Okay.
Yes.
It's really important to me that you know those two things because they're true.
Right. Hmm.
So here's what I'm going to say. I would love if you could work with me and we could be together emotionally if we can't be together physically. Can we do something together? Can we go on a trip together? Could we talk about going maybe to New England? I'm going to get a map out. And I'm wondering if we went to New England, would you rather go to Vermont or would you rather go to New Hampshire? What do you think?
Oh, that's a great idea. She'd love that.
Yeah.
Yeah.
You know what? If we went to New Hampshire, would we go to the mountains or we want to go to the beach?
Right. Yeah. No, that's perfect. She
So,
would.
mhm.
Yeah.
So it's not ideal, but it's what you can do. And
Right.
she has language, she has abilities, she has some skills.
Oh, yeah.
Her main thing is anxiety. In other words, I want to be with you, I want to be safe, I want to be in a place. And so what you're giving
Yes.
her is what you can do is be with her and offer her something to do with you that she'll enjoy, that both of you can enjoy, and that you have a sense that you're going somewhere and doing something. Um, and we started off though with, you remember when you told me that we had to stay in school? And I think you need to come up with something like that.
Right.
Just like you had to at some times go do stuff you didn't like doing. That's where we are. Ooh, but then use the interjection and not an explanation, just an interjection. Oh, hey, mom. So if we were going on a trip to wherever it is, you pick your place. But it's that opportunity to make a journey together, go somewhere together. Not if you're going home, you're going on a trip.
And
Now, shall
that's
we?
great because she's very tangential. So she'll start. I try to ask her questions. Hey, mom, what do you think of this or that or opinions? But it'll always come back to I want to go home. But
Yeah.
we can keep going back around, going to different places or
Yeah, because I think that's the thing you can offer her in your bed,
right.
not able to get up, not able to go do things. You could do on this trip with her as well. I mean, you're like, you know what, we should do this time, mom. I know you want to go home, but before we go home, we're going to go to Niagara Falls.
Yeah.
Now I'm going to tell you something. I don't want to go down the main street because they sell all kinds of crap there. What I want to do is go to the park where you can see the falls because the falls are something else. The crap in the street. Here, I have a picture for you. Let me show you this. This is crazy. Look what they have on that main
Yeah.
street. It looks like Vegas. I've never seen it so weird.
That's great. Thank you. That's a wonderful idea. I'm going to definitely try that and
Give
and
it a
see
try because
how it
I mean,
lands.
it can't get a whole lot worse than where you are, which is the crying and please, 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 please come get
Yes.
me. Yeah.
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 And the really sad thing is that her grandkids absolutely love her, but they're in college and can I come and stay with you? And they right now they're having a hard time. And I know that they love her and they want to be with her. So if we can find a way
It's the
to settle
it's her
things.
it's the whining, quote unquote. I'm just going to call it like we hear it. It's the
Yeah.
whining. I want what I want. I want what I want. I want what I want.
Yeah.
It's the
And
kid in
it'll
the back
escalate
seat.
to anger. You
Yeah,
know,
and then she's angry
your
with us
sister
because
brought me
we
here. She threw me here. Yeah.
and then we feel that's
Yeah.
not fair. And so then we have an emotional reaction to it. So yeah,
Right.
no, it's just a way to try a different journey because
Yeah.
she's stuck and you're stuck.
Yeah. Well, thank you. Thank you very much for answering my question. I
Yeah,
appreciate
no,
it.
good. You're welcome for sure. Cheryl Ann, you have your hand up. Tell me more. Well, you're all muted. So that's not working. You took your hand down, but you're all muted. We need to hear you. So
There
there
we
you
go.
go. Good. There you go.
I was just a short-term mute. as I was listening to you, I think one of the most important things is, as daughters or family members, when we hear that, all of our guilt and fear and anxiety wells up. And it's just a horrible, like, we give that to them and then they give it back to us, you know? And so my thing is when I was like 20 something years old, my mother made me promise that I would never bring her into my house. Now, sometimes I'll say, Mom, remember, I know you probably don't remember, but when I was like 22, you made me promise that you couldn't come stay in my house. And you don't want to. I have to get up early for work in the morning. You tell me I'm not a good housekeeper. I got the dog will sleep in your bed. And she's like, you're right. But really, she wants me to kind of meet her where she is and spend time with her, you know?
Yeah.
And I think that really came to my mind once when I was with her and we left memory care to go to the assisted living side. And she said, oh, I'm finally home. And so I heard that and I panicked, right? And then she said, honestly, I don't have any idea where I am. I just know that I'm with my daughter and I love you and I feel comfortable. And that to her was what she was looking for.
Yep.
So when you share the stories, like share stories from your past and what you did and make her feel like you want her. Like I see daughters all the time go, no, Mom, you're staying here. I've got to go home and cook my husband dinner. The kids are waiting for me. Boom, boom, boom. And really, what she should have just said was, I'm leaving you here by yourself, Mom, because I have something more important to do outside, which, you know, is not necessarily the case, but I mean, it kind of, that's how it.
I wish I could. For right now, though,
Yeah.
I got to run to the store. Oh, here. Question, Cheryl Ann. Would you rather I bring you ice cream next time, or do you want me to stop and get some cookies for you?
Both.
Both. Okay, chocolate or vanilla then?
Chocolate.
All right, you got it. You got it. I promise. Love you.
All right, I'll see you tomorrow. Love
Okay,
you too.
you got it. Yep. It's hard. I mean, there's nothing easy about this whole thing, but how we choose to respond to those episodes of frustration in ourselves that I can't do, I can't be, I don't know where to go with this. Asking the question, I think I could use some help. Robin, thank you for asking, because I
Thank
think,
you.
yeah, that opportunity to say, I could use some help is a really important one when we're in this mix, because we never know, we're going to get stuck. I could use some help. Doing an IV, having one nurse say to somebody else, I could use some help. My person is going to need some support so that I can do the IV part. And I don't need three burly guys holding somebody down. I need somebody who's skillful at supporting someone so they feel supported, so we can get the IV in and keep it in. Because that's the other piece. If we're going to try it, we want it in there for a bit, or I don't know why we were bothering to put it in. Were we drawing blood, or are we trying to get an IV in? So working through those things, I think, makes a difference. So Rachel, I think we're almost out of time. You got something
We
that's going to
are
take 3
almost
minutes?
out of time.
No, you don't have something that's going to take 3 minutes, do you?
Well, we have one you could try. You up for the challenge?
In 2 minutes? Okay,
Well,
go for it.
you good.
Go.
So this was from someone in YouTube. They said, how do you help someone who constantly wants the curtains closed as soon as, I'm not sure if it's 10 p.m. at night or 10 a.m. in the morning, but others want them open so they can see outside. The person has been told that outside is dangerous. They were living at home before. So I'm guessing that they were told outside is dangerous. They want the curtains closed and other people want them opened.
Yeah. And so we have a situation where looking toward the windows is scary if the curtains are open. Did I give you a hint about a possibility to try? We want to look at the direction of the person and what they're looking at and what they have to do. So I think sometimes if I walk into a room, you go, that's really not looking good out there. Okay, tell you what, come over here with me. And we may look for nooks that don't have outdoor windows, or we may look for where we have chairs that have a corner that give us some protection from it. Maybe we take the curtains a little way across the window and we position the person so that they are seeing the curtains a little bit out on the window and think, oh, okay, she closed them. But we've got to move into a space where we don't have the person looking at the thing that we realize they feel is unsafe. Having her look at it is probably not a great idea. Yeah.
Well, I'm thinking that maybe they're not wanting to look outside the windows and other people are wanting to look outside the windows, but now that's become a dangerous thing outside, and so it doesn't feel safe anymore.
And so not having them look that way is one of the first steps, is not bringing them to and having them exposed around windows. Let's move into a part of the building or part of the space that does not have that window treatment.
Ooh, Tipa.
Yeah.
Oh, you're right. That is not okay. Let's get away from that window. Come here.
Okay.
But then when we're away from that window, and I think this is the piece that we're kind of hinting at. You said the first step. The second step is, do we have engagement?
If we don't have engagement away from that window, we'll be right back at it because we're worried. So we've got to find something to do in a space that doesn't emphasize the window. And we've got to have somebody engaging the person. If we don't have that, we'll be right back at this again because there's nothing else to look at except that unsafe space. So we got to figure out things to do in the space that doesn't expose the person to that window, but we've got to keep them engaged. Oh, that sucks because it means we're going to have to engage them. We don't have people. We better get some people. Maybe we need some volunteers. Maybe we need a family member who's willing to work with 3 people, not 2 people. Maybe we go to a space where there's something going on and there aren't windows. Believe it or not, I know in most buildings that exists. Actually, I'm typically in one of those rooms, or I used to be. Now I'm in a space. Oh, let me show you my window. There it is. Up there. That's it. That's the only window in my room. That's what I got. So maybe we look around the space and find a space that doesn't have a big window, that this person could actually make their own, create a little nest, create a space that feels safe. I'm pretty sure that window up there, I could cover that one up. Nobody'd even worry because it's so small. You can't even tell there's going to be something coming through it. Well, there might be. We might get ants. All right. So for today, I think we've run out of time. So Matthew, anything you want to bring back from the YouTube world?
Yeah, a huge thank you to everybody who participated, gave comments. I shared those in the chat so the Zoom team would see them. And also shared the questions because we got a chance to sneak one of those questions in there at the wire. So thank you to everybody. And for sure, share this out because I have a feeling there is somebody out there who could use what we talked about today, who could literally have that moment of, wow, I really needed to hear this today. But that can only happen if you share it out and keep that ripple going so that it will be out there for others to catch. Because we love to see that folks make connections to the things we talk about, because that's a big part of why we do this, is to help cover questions and support others who are going through a lot of the same things. So thank you all.
Thanks everyone who came. Thank you for everything you do. Big thank you, Cindy, thanks for taking the effort to be here after your 7 days or 6 days of visitation. And for all of you who came with questions, comments, thoughts. Jeffrey, thanks for taking the heat from TIPA, and thanks for coming back. And Cheryl-Ann, thanks for sharing your story. And for the rest of you, thank you, Robin, for your question, and Esther for yours. Rachel, thanks for all the help. And thanks, team. Till next time, take care with your care and take care of yourselves.
Yep.